Okay, can everyone on Zoom hear me? Okay. I hope everyone on Zoom can hear me. I don't know either. But like yes, okay. Pretty sure yes. So okay, perfect. All right guys, so I'm gonna get started if that's okay. So just for anyone, I know for everyone who doesn't know me, I'm Sophia. I'm one of the 6-year EMI Crips, and today I have the pleasure of talking about critical care toxicology. So I always like to start with why is toxicology important? So, you know, as critical care doctors, we need to have a high suspicion for basically a poison patient. Often our patients will have toxic exposures, illicit drug use, suicide attempts, and so this actually becomes quite important in critical care. So I just start with a case. So a 21-year-old girl comes into the emergency department. She's tearful, stating that she took a bunch of pills 3 hours ago after her boyfriend broke up with her. She really is only a little nauseous, a little diaphoretic, a little pale. Nothing else is going on. Yes, exactly. Not that it's ever happened. And then we have a second case. So you actually have 2 patients come in. You have a 63-year-old male. He has a history of house arrest. He has chronic shoulder osteo, and about a week ago, he started getting flu-like symptoms. He had fever, myalgia, so he started taking even more fever-reducers. And when he came in, he had an INR of 6.5, AST and ALTs in the 6,000s, elevated GLDs, and an ammonia of 70. He was otherwise hemodynamically stable. So you guys can probably guess our first topic today is acetaminophen overdose. So it's actually the most common cause of acute liver failure in the U.S. and the most common cause of liver transplant in the U.S. There's about 60,000 cases yearly. 50% are intentional, like our first patient. 50% are unintentional, and about 500 people die every year from acetaminophen overdose. So when you're thinking about the unintentional ones, people don't actually realize how much Tylenol is in other products. There's actually 600 different over-the-counter prescriptions and medications that have Tylenol in them. And you can see from this list things like Benadryl can have it, Dayquil, Robitussin, Zicam. So people often overdose because they don't realize Tylenol's in so many different products. So when you have a Tylenol overdose, another thing you really need to know about are the co-ingestions. So you can have salicylates if someone takes Excedrin, you can have ibuprofen, you can have diphenhydramine, you can have dextromethorphan. Opioids are actually big. The FDA actually, one of the reasons they had to limit Tylenol in products like Norco was because people were overdosing on Tylenol. And then you can even get barbiturate and caffeine overdoses if they take something like Fioricet. So how does Tylenol itself work? It's an analgesic and an antipyretic. It's actually technically an NSAID because it indirectly inhibits the COX-2 pathway, but as we all know, it has very weak peripheral anti-inflammatory properties. So how do we define a potential toxic dose? So we all know 4 grams of Tylenol a day is usually our max if you have normal liver function. But we'll usually say a single ingestion of 150 milligrams per kilogram or 7 grams at once. The 7 grams vary. Some sources say 7.5, some say 10 before toxicity. So I just chose the lowest one to be safe, basically. And then we have 2 types of ingestion. There's the acute ingestion and the chronic. That's called repeated supratherapeutic ingestion. That's like our second case. Our gentleman who was already taking Tylenol for osteo and then started taking it for and then extend it over a greater period of time, 150 mg per kg. Things to know about Tylenol, it's actually absorbed rapidly throughout them. You get 6 hours. However, if you have any so your opioids, your foods, any of your antihistamines are all going to delay that absorption, especially if you get that gastric emptying. So let's actually talk about how Tylenol itself is toxic. So I actually think Corinne went over this last week a little bit, but we'll go over it again. So Tylenol, it goes to the liver, and there's really 3 main pathways. You have your glucuronidation, you have your sulfation, and then you have your NAPQ pathway, which is a cytokine P450 enzyme. So for the majority of times, whenever you take Tylenol, the biggest pathways are glucuronidation. Your second one is your sulfation. Only as much as 10% usually goes and forms NAPQ. This is NAPQ up here, your N-acetyl-P-benzoquinonamine. So normally your body has a pretty good mechanism to deal with NAPQ. You use glutathione, you actually take it into a cysteine and a mercaptic acid adduct. These adducts can then be renally excreted. But the problem happens in overdose. These two pathways, your glucuronidation, your sulfation get overwhelmed, so you shunt more down this NAPQ pathway. Then you tend to deplete your glutathione stores, and once that happens, NAPQ, as you can see, it's got this group here, it can actually covalently bond to the hepatocytes. It's an intramitochondrial protein it binds to. That leads to hepatic necrosis, and that's really the damage. Itself, like your kidneys also have this 2E enzyme, and that's what they think is causes the renal toxicity in Tylenol. So basically, if you lose your glutathione, you can't take NAPQ into these benign metabolites. You bind covalently to your hepatocytes, and you get hepatic necrosis. So how does Tylenol toxicity present? There's actually 4 phases. You have your gastrointestinal, your hepatic injury, your hepatic necrosis, and your recovery. So we often see patients in the first phase initially, the gastrointestinal. They're very mildly, they can either be asymptomatic or have mild GI symptoms. Really, the only sign that you're going to find is an elevated Tylenol level. They won't have any signs of hepatic injury yet, and this is 0 to 24 hours. Now, the one exception is if you have a massive overdose. If someone takes like 20 grams of Tylenol, they're going to skip this kind of acute asymptomatic phase. They're probably going to present in this jaundice encephalopathy phase. So they can look falsely very good when they first come in. Then they start to transition to phase 2. That's when you get the hepatic injury. That's when you get your AST elevations, your abnormal LFTs, your coags. That's 24 to 72 hours. AST is actually the enzyme that peaks first. It elevates and falls before ALT. So if you only really have 2 labs that you can order, I would order a acetaminophen level and an AST. And then hepatic necrosis, this is the severe stage where you get jaundice, encephalopathy, hemorrhage, you get metabolic acidosis, coagulopathy, renal failure. That's 72 to 96 hours. And then if you recover, if you make it to phase 4, you actually will not have any permanent liver damage. So you want to get to the recovery phase. So what are risk factors for Tylenol toxicity? So elevated age. So the older you are, the less you're going to be able to handle basically acetaminophen overdose. Alcoholics and those who are malnourished actually have a glutathione deficiency at baseline, so they tend to have a worse outcome with acetaminophen overdose. Interestingly enough, in Gilbert's, they have a deficiency. If I go back to this slide, they have a deficiency in the glucuronidation pathway, so they are more susceptible to Tylenol toxicity because they shunt more through it to the NAPQ pathway. Pregnancy, one of the reasons they think that pregnant ladies are more susceptible to acetaminophen overdose. It's just that what's the one medication we give all pregnant ladies? Tylenol. We give it for everything. It's one of the only safe medications we have for pain in pregnancy. And then your anticonvulsants, your opioids, anything that affects your cytokine P450 can affect your Tylenol. So how do you diagnose this? Really, it's going to be your history, your physical. In any tox case that we talk about today, it's really getting pill bottles. So you can know, is it an extended release? What are the co-ingestants with it? So it's going to be asking EMS, asking family to search the house for pill bottles so you can quantify how much they took and you can see what else they took. You want to always get a glucose in any tox patient. Usually a urine drug screen. A lot of our patients come in with co-ingestion, so they'll be intoxicated and they'll have an acetaminophen overdose. You always get your salicylate level, your LFTs, your INR, mag box, EKGs. These are going to be things that toxicology wants to know on all of your patients. And then the acute ingestion is going to be your 4-hour Tylenol level, which we'll talk about. You can get, if you have an acute one-time large ingestion, you can get your acetaminophen level anywhere from 4 to 24 hours, because that's where we're going to use our Rumac-Matthew nomogram. And then for the repeated supertherapeutic ingestions, any positive Tylenol level when you've had greater than 4 grams in a 24 hours and any LFT abnormalities, those are going to be important things for treatment, which we'll talk about shortly. So I wanted to stop really quick and just talk about what should you do for physical exam for a tox for a toxicology patient. So there are a few things you should do, and these are going to help you differentiate between a lot of your toxidromes. So vital signs. So are they hyperthermic? Are they tachycardic? Are they hyper or hypotensive? You're going to always actually have to look at pupils. So do they have meiosis? Do they have mydriasis? Do they have any nystagmus? You're going to look at their skin. So are they dry? Are they wet? Are they red? Like are they pink? And then muscle tone, you're actually going to need to know, are they hyperreflexic also in bowel sounds? So if you're going to do a tox physical exam, I kid you not, if you ever have to call Dr. B, she's one of our toxicologists, she's going to ask you if there's axillary sweat. So get ready to put a glove on and feel. This is going to be one of the first things she asks on all your patients. So labs, this is just kind of what you'll notice in an acetaminophen overdose. So your AST is the first liver abnormality that peaks and then falls sooner. Your ALT is a little bit later, your INR, your creatinine. So, after, basically after you know that you have or you're suspicious that you have a Tylenol overdose, at what point are you going to call toxicology? I always say get them involved early. They're going to help you make that decision. Poison control, and these are our two toxicologists, Dr. Malone and Dr. B, and then poison control is very helpful too, especially because we rarely get the acute ingestions. We often get the chronic, super therapeutic ones. And so you're like, can I use the Rumac-Matthew nomogram, which we'll talk about right now. So this is the Rumac-Matthew nomogram. This is what you're going to use when you get a patient. So levels before, when you have a patient who has an acetaminophen overdose, a level before 4 hours is worthless. We can't interpret that. So what you're going to do is at 4 hours after the ingestion, you're going to get a level. And you can plot it on this gram anywhere from 4 to 24 hours. And there's 3 lines you'll see. Mostly you'll only see 2. The red line isn't on all of them. But there's the actual Rumac-Matthew line. You can see this dotted one here. This is from their actual study. And this indicates if you have a level, like let's say you're at 12 hours and you're above this line, if you have a spot, an acetaminophen level above that level, you're likely going to have hepatotoxicity. And without treatment, you're going to have a 60% chance of severe hepatotoxicity, a 5% mortality. Now, the reason we have the line, we actually use our treatment line, the 150 line. This is the FDA line. Basically, they wanted a margin of error, a 25% safety margin, because we never know exactly when people take it. Our patients aren't always the most reliable, and so they wanted to make sure we weren't inappropriately missing people that should be treated. And then the 300 line, this is just severe toxicity. You're going to have a 90%, if you're above this red line, you're going to have a 90% chance of severe hepatotoxicity and a 24% mortality if you're not treated. So it just kind of helps you figure out how sick is my patient. And then just a little caveat, this can only be used for single acute ingestions. It can't be used for the repeated supertherapeutic or any, even with your sustained release or co-ingestions that decrease absorption, you might not be able to use it. So that's when you'll want to actually have toxicology on board to help you. So how are we going to treat acetaminophen overdose? I know you guys know this, but one of the first steps is actually activated charcoal. So we dose this 1 gram per kilogram, and there are some contraindications. So the stuff is like thick, black, it doesn't taste very good, and it doesn't smell very good either. So patients often have trouble because if they come in with an acetaminophen overdose, they often have some GI complaints, so it can be difficult to get your patient to be able to take this. There are absolute contraindications, so people who have an unprotected airway and are high risk of aspiration, they have bowel obstructions, or if they took something corrosive, and those are going to need an upper endoscopy, you cannot give activated charcoal. Otherwise, make your patient start drinking this, 1 gram per kilo. So then, as we know, the antidote for acetaminophen is N-acetylcysteine. So early on, once they figured out the mechanism of acetaminophen, they actually found out that there were certain compounds that would replete glutathione stores in the liver and prevent liver damage. The first ones were actually methionine and cysteamine, but people had horrible side effects. They would have flushing, vomiting, and one of the original papers, they actually described it as misery. So even though they decreased their liver damage, it was horrible. So when they developed N-acetylcysteine, people had very few side effects. So it prevents there's different studies on N-acetylcysteine, and these are some of the things that they've noticed. It prevents renal injury, it improves hemodynamics in people with massive overdose, it decreases the rate of cerebral edema, and it's going to prevent hepatic injury. So I just want to take a quick side note on chronic Tylenol use. So these are patients who have recurrent elevated doses like we talked about earlier. So when are you going to decide to treat them? So right now, usually any patient who's asymptomatic who's had elevated more than they should, anyone who has an abnormal more than 4 grams per day, or anyone where you're really certain that their liver disease toxicology will help you on this, but you don't have to delay your treatment. So when should you actually give NAC? What's the time range? So this is one of the studies from 1979, and this is by Prescott. So they took patients, this table specifically looks at patients who were high risk, so people who had massive overdoses, and they looked at time frame. So the people who got treated, as you can see here, in less than 8 hours, 0 went on to have, there were 19, 0 went on to have severe liver damage. From 8 to 10, you can see as you go further out, from hours, so like 15 to 24, 9 of those people, or 82% of the people of the 11 who had it, have liver damage. So based on this paper, we kind of have a few conclusions. There was complete protection against severe liver damage if you were treated within 8 hours. Treatment after 15 hours was pretty much ineffective. That was their conclusion, given the fact that 82% of people still had severe liver disease. And then renal impairment, they found in this same study that if N-acetylcysteine was given within 10 hours, that there was actually no renal impairment, lasting renal impairment. So that's kind of where the 8 hours, and you always hear toxicology say, like, try and treat within 8 hours. This is the study that it comes from. So should you guys use oral, and NAC, or IV? So they both have been shown to have similar efficacy. Feels significantly less expensive. It does have a really unpleasant smell. These are just ours. We have a Henry Ford Tier 1 policy that was written by Toxicology for oral and IV NAC, and this is just kind of what they list our indications for IV NAC, and it alters mental status, pregnancy, if you have a gastrointestinal obstruction, if you have a GI bleed, or if you have any signs of shock, they recommend IV over PO. So I did want to quickly go over the oral protocol. You can actually, this is the link that you can click on for our policy on 1 Henry, but basically the oral loading dose is 140 milligrams per kilogram. And then you do 70 mg per kg every 4 hours. It literally goes through. In the past, they actually recommended a 72-hour oral protocol, but we no longer do 72 hours. So this is our IV protocol. You guys can just take a quick look at. If you ever need this, like let's say, the second patient we had, he actually had he was actually a patient I had on B1. You can actually concentrate it so that you give less fluids, because this is a 21-hour protocol. It's a lot of fluids for our patients who are fluid sensitive. They even have suggestions of diluting it if you have patients with cerebral edema. So our policy online is really good, and toxicology can also help. So when you guys are kind of thinking about the duration of oral NPO, how do you know? So it's actually an area of controversy. So the oral, like initially whenever they did an oral dose, it was 17 doses, 72 hours, and the IV was a 20-hour regimen. It's kind of like, looking at cases, there's no good studies on duration, but if you look at cases, there's people with massive overdose where 20 hours is not enough, and there's people with like very small overdoses where they really don't need 72 hours. So really what you can do is look at your acetaminophen levels. If it's undetectable and your AST and your ALT are less than 1,000, it's generally what toxicologists recommend for stopping your therapy. And like I said, if you have a massive ingestion with acute liver failure, 20 hours might not be enough and you might have to extend it. So the one big side effect of IV NAC is an anaphylactoid reaction. You'll get rash, pruritus, angioedema, bronchospasm, tachycardia, hypertension. It's more common in patients who have asthma, especially the bronchospasm. sulfa allergy is actually not a contraindication, and it is contraindicated in people who've had a severe anaphylactoid reaction, but I'll tell you, for the most part, most treatment protocols recommend actually treating, so giving like Benadryl, giving steroids, and trying it again. Like if it's IV and they have even like hypotension or bronchospasm, they should stop it for an hour, treat for that, and then try restarting at a lower infusion rate. So, I mean, it is really protective of your liver, so they kind of take a pause and retry approach. So, can you dialyze Tylenol? Both Tylenol itself and NAPT are dialyzable. There's this really cool group, you can just Google it online. It's the EXTRIP group, which is the Extracorporeal Treatments and Poisoning Work Group. If you're wondering if a substance can be dialyzed, literally just Google this group, and they have literally all the indications, contraindications. It's a group of nephrologists and toxicologists. So there are some indications for dialysis and Tylenol overdoses. And then when should you consider transferring? Let's say you're at an outside hospital, you don't have a liver, you're not a liver center, or even when we get patients in our MICU, when should we consider like calling hepatology? So there is a criteria for liver transplant. You have to have a pH. You either have to have a pH less than 7.3, excessive lactatemia, elevated lactate after fluid resuscitation, or you have to have a combination of all three of these things: an INR greater than 6.5, a creatinine greater than 3.5, and 3 or 4 hepatic encephalopathy. If you have any of these people and you're not in a liver, if you have any of these criteria and you're not at a liver transplant center, you should send your patient. There's a lot of the ATMO calls we get. And then if you are here, you should consult hepatology, and they should be worked up for liver transplant. So I have some candy, if you guys, and I have some random tox questions for fun. So what toxic inhalant can classically cause a non-NN-GAP metabolic acidosis from an RT? You can see these patients actually come in. They look like they have like paralysis. They can have severe hypokalemia, Yeah, you got it. It's really toluene. So you'll actually see the people come in like huffers. They'll like put it on. They'll put paint, like metallic paint is really popular. They'll put it on a rag. They'll breathe it in, and they can come in completely altered. They often get intubated because they can't even move their limbs. They're paretic. And it's honestly in paint, glues, adhesives. So that's it. You have some candy? You have some candy? Okay, are we going to see that? Okay, guys, and we'll move on to our next topic. So we have a 65-year-old patient. Some of these are real. This is a real patient. 65-year-old female with schizophrenia who was found altered on the boulevard. No one knew anything that happened. She had a respiratory alkalosis and a metabolic acidosis. What do you guys think we're going to talk about today? You got it, salicylate toxicity. So with salicylates, they've been used for years, from the ancient Egyptians to Hippocrates to Bayer when it was first registered in 1899. And it's found in multiple products, so oils, wintergreen, Pepto-Bismol, Excedrin, Stanbac, Bengay, wart removers. A lot of them can have salicylates. Stanbac is a popular one in Detroit. When I first came here as an intern, all my patients were taking Stanbac, and I had no clue what it was. It's like a powdered aspirin. So you'll see that one in Detroit a lot. So there are 25,000 listed exposure support and control centers each year. Often there's a delay in diagnosis, which we'll talk about in a little bit, from salicylate. Therapeutic range is pretty low, 15 to 30 milligrams per deciliter for stored in the stomach. And then there's also, there was recently a paper in New England Journal on, watching out for salicylate toxicity, because during a previous pandemic, the Spanish influenza in 1918, there were several cases. So they were basically saying we should be familiar with this because maybe during COVID, everyone will take aspirin and we'll have a lot of salicylate toxicity. So it's just, how does aspirin work, or salicylates? Irreversible inhibition of COX-1. Most of the salicylates have been studied as aspirin, so almost everything is based on aspirin. So how is it toxic, though? So it actually interferes with the aerobic metabolism because it uncouples oxidative phosphorylation in the mitochondria. So if you want a really complex mechanism for all the different things it does, you can look at this picture. It is a little too hard to comprehend, so I have a much easier one. So basically, salicylates just inhibit your Krebs cycle. So your pyruvate eventually goes through your Krebs cycle. Eventually, you get ATP. It basically stops your Krebs cycle over here. So if you can't go through Krebs cycle, you get that uncoupling of your oxidative phosphorylation, but you also get your pyruvate being diverted backwards into making lactate. So you're going to get a lactic acidosis. And we'll go over everything that you can see. We're going to talk about presentation, just so you can see big picture, and then we'll get into specifics. You're going to get hyperpyrexia, lactic acidosis, metabolic acidosis, respiratory acidosis. So, sorry. So how is your patient going to present? So often they will actually be hyperthermic, so they'll have a fever, they'll be tachypnic and hypertensive. So this is a little more like Chrysanthemum. They're going to be taking really deep breaths, and they're going to be breathing very quickly. They're going to be often tachycardic and sporadic. They're going to often have GI symptoms, so nausea, vomiting. They can even get a hemorrhagic gastritis, leaking hemochemesis. They can get abdominal pain, diarrhea. If you take, they can actually get pharmacologic sores in their stomach. Really interesting, especially with enteric-coated aspirin. And when that happens, you can see sustained release and sustained toxicity. So there's quite some unique, sorry, can I take my time? There's some unique findings, like in the central nervous system. You get tinnitus, deafness, vertigo, ataxia. You get a whole spectrum of delirium, lethargy, coma. You can get serotonia and seizure. With the tinnitus, there's multiple mechanisms. Goldbank's textbook on toxicology has about 3 different possible mechanisms for the tinnitus. They actually really isolate based on it. So pulmonary effects, this is really important for us. I actually did not know this, but there's actually, you can develop ours from salicylate toxicity. It's actually about 7% of cases. It can be an acute overdose or chronic salicylate, and it is associated with certain characteristics. Cigarette smoking, chronic overdose. If you have a metabolic acidosis or presenting neuro symptoms, you're more likely to get ARDS from in the setting of your salicylate toxicity. And then classically, you're going to have an anti-gut metabolic acidosis. It's multifactorial. So it's from that lactic acidosis. You actually have an increase in your fatty acid metabolism, which generates ketone bodies. So you have a ketosis. You have impaired renal function, which leads to the accumulation of inorganic acids. And then salicylate and its metabolites itself are unmeasured anions. So this is how you get an anti-gut metabolic acidosis. You get a respiratory alkalosis because salicylates themselves actually stimulate the medulla of the respiratory center, and that leads to dyspnea. So there is one pitfall that you can see in your lab. You have a falsely elevated chloride. There's a lot of labs that have salicylate for chloride, so one kind of interesting thing to look out for. And then glucose. So there's actually this and there's cerebrospinal fluid. So patients neuropsychosis, which is and the name for that is hypokalemia. So often, glucose supplementation. So this is just kind of the this is one study, and they kind of said what percentage of our patients will have these symptoms. So about 61% had neuro symptoms, 50 had acid-base disturbances, 43 had pulmonary complications, 38% had population, 20% were hypogastric, 40% had. And the important thing about salicylate toxicity is it's activated, so it often gets excited. There's one study with diagnosed with this, and interestingly, in this study, a lot of them had neurology consults prior, so they weren't even thinking about it. So just like Tylenol, we're going to actually use this activated charcoal 1 gram. There actually is pretty well because there actually is some holes for resistant so that would be good as urine, and how do you actually alkalinize your urine? You're going to set the side part, Can you guys hear me better now? Sorry, I don't talk too much. Okay, because I talk me. Okay, can you guys hear me a little better now? I can talk louder. Okay, I put it on speaker. Maybe that was it. Yeah. Okay, so basically we're talking about alkalinizing your urine. So if you guys remember, this is part of the kidney and the collecting duct. You have your, basically your ion potassium ATPase. So if you're hypokalemic, what your body is going to do is to reabsorb potassium from your urine into your blood, and it's going to excrete ions into your urine. So you're never going to be able to alkalinize your urine. So that's why you have to aggressively replace your potassium on these patients, or you will never achieve urinary alkalinization. So if you've ever tried it and you see you're just not doing it, often it's because your patient is hypokalemic. So aggressively replace your potassium. And then for hypocalcemia, because these patients are on bicarb and they're alkalinized, they often get hypocalcemic, so you just need to monitor and replace. So this is just one of the things. Honestly, if you're going to have your patient on bicarb with D5, you probably don't need to give them glucose, but otherwise you need to supplement their glucose also. So dialysis is indicated in salicylate toxicity. The more massive the overdose and the more unstable that they are, the sooner you should consider getting nephrology on board and dialyzing them. These are just all the specific indications, contraindications. And during all of these, you're going to continue to try and alkalinize your serum and your urine to get rid of the salicylates. So a few things that you really have to be concerned about with salicylate toxicities. So these people, because they're hyperpnic and they have minute ventilations that are 20 to 30 liters a minute. So if you decide to intubate them because they're altered, they're not protecting their airway, they're going to very quickly from apnea and from just the normal ventilator settings have a drop in their pH. And remember, anything that drops the pH is going to increase the toxicity because it increases the non-ionized form and absorption into the brain, and it prevents it from being excreted in the kidneys. So you need to take that into account. So most people will actually bolus some bicarb prior to intubation. They'll have the most experienced intubator do it so that it can be the shortest the shortest period of apnea possible. And then also, these patients are also often delirious, altered, aggressive, and they get chemical sedation, but anything that decreases their respiratory drive is going to affect their pH and lead to worsening toxicity. So you just have to be really careful with these patients with sedation, with intubation. You really want to hyperventilate them if you do intubate them. So just a few things. You're going to need ICU level care because you're going to need 2 to 4 hour salicylate levels. You're going to need early hemodialysis. And then you're just going to have to be really careful with their mental status and mechanical ventilation. So just another, sorry guys, some of this is it's a lot of intense, like biochemistry, but just for a minute break. So do you guys know 3 medications that can falsely cause a positive tricyclic antidepressant screen on your urine drug screen? Say it? Okay. Anyone else? This is just for fun. But again, you want a clue? Yeah. So we use it for delirium in the ICU all the time. Yep. So Tegretol, Flexeril, and Seroquel, because we'll actually get a lot of patients. There's a lot of false positives that you can get. What is the one thing that you never get any false positives with? Cocaine. Cocaine is only cocaine. These are just some fun talk facts. Okay, so let me just look at time. Okay, so we have a 30-year-old woman who has a history of depression and anxiety. She came to the ER just restless, hypertensive, in her upper extremities. She was recently increased on her Paxil dose, and she has really bad insomnia, so trazodone was started. What are you guys worried about in her? Yeah, serotonin syndrome. This is my actual patient in the ER too. So serotonin syndrome, it is a rare life-threatening drug reaction. It can happen at therapeutic dosing. So Paxil is one of the most common therapeutic dosing SSRIs that can lead to it. Drug interaction is the biggest one, and then people who overdose also. And just so we go over it really quickly, it's a monoamine neurotransmitter. It's synthesized primarily in the GI tract, but there is some synthesis in CNS and the platelets. So these are drugs that are associated with. Big ones that we always see are antiemetics. We see linezolid a lot, and then SSRIs. All of these are possible. So how are they going to present? So this is where your Tox Physical, if you just go head to toe, it's going to give you all your answers. They're going to often be febrile, tachycardic, diaphoresis. They're going to have mydriasis, hyperreflexia. It's usually worse in the lower extremities than in the upper extremities. They can have clonus, increased bowel sounds, and they're going to be very agitated often. So what is the treatment? You have to stop the offending agents. That's the most important thing. So if it happens because they're on, like the cases that we've had in the ICU, sometimes they're on hydrosphenol. We start some oral opiates. They're on linezolid for their like MRSA, bacteremia. So you stop the agents that are causing it. Fluids and supportive care. And then the biggest treatment is actually benzos. Benzos actually, irrespective of the severity of symptoms, have been shown to have a mortality benefit. So in these patients, benzos, you want the benzo hammer. So do you guys know what famous court case dealing with toxicology issue led to the eventual establishment of our duty hour? I can tell you that it probably has to do with serotonin syndrome. Do you know what case? The Tremolo. Oh, the agent. So it's actually like the name of the court case, but do you guys know the patient? It's a patient. It's a famous patient. It's New York. You got it. It's just have some candy. Have some candy. It's actually just the Libby Zion case. So she basically was a patient who was cocaine positive. She was on a MAO inhibitor, and then she came into the hospital. She ended up getting like some meperidine for pain. She got multiple medications, and it went to court. And the residents actually said they had been working for like 30-some hours. That one of the reasons they didn't notice it, like they didn't catch on to it, was because they were too tired. So that was like partially their defense, being too tired. So eventually New York developed like duty hour restrictions, and the ACGME years later did it too. So it's all because of this case. So gonna switch gears a little bit, guys. Hang in there. We're getting close. The next toxidrome we're going to talk about is the Brady hypotoxidrome. So there's kind of different branch points that you want to think of whenever someone comes in just bradycardic hypotensive. So you have your sedative hypnotic one, that's like your opioids. They'll have the pinpoint pupils, they'll have the altered mental status, the respiratory depression, and then I like to think about the 4 cardiac medications. So your clonidine, like your sedative hypnotic one, you'll have like, the pinpoint pupils, and they'll have the partial response in Narcan. You have your DIDs, which we're not going to talk about today because of time, and then we're going to talk about beta blockers and calcium channel blockers. Biggest differentiation between the beta blockers and the calcium channel blockers are your glucose, so hypoglycemia versus hyperglycemia. So these are the 4 that I think about when I think of a patient coming in Brady hypo, if I'm thinking tox, and we'll get into it. So this is a 69-year-old woman. She came in after a suicide attempt. Initially, you only knew it was a beta blocker and a calcium channel blocker. Later, you found out it was a tenolol and amlodipine 5 hours prior to coming in. Her blood pressure was 69/35, and her heart rate was 40. So let's talk about beta blockers first. So just very briefly, propranolol is like the one that has been largely ingested the most in self-poisoning. Interestingly enough, they think it's because there's so many indications for it in anxiety and other like anxiety disorders. I think that might be why it was the beta blocker that was most implicated in this. And then one important thing to know about your beta blockers, some are highly lipid soluble, like your propranolol. Some are highly water soluble, like your atenolol. That will be important in treatment. And then the toxicity we know is just because of their mechanism. They basically competitively antagonize the action of catecholamines. Usually, if you have a patient who's had an overdose and they have no symptoms by 6 hours, they're safe to go home. They're not going to. The only ones you have to be careful on are the extended release, like your Toprol XL or your Sotalol. Sotalol is known for having a delayed presentation. So calcium channel blockers, as we know, calcium channel blockers have huge indications. So from Raynaud's to migraines, to clusters, to subarachnoid hemorrhages, in addition to blood pressure. And they're actually one of the leading classes of poisoning fatality. So calcium channel blockers I always think of as being a little worse than beta blockers. One distinction we want to make with our calcium channel blockers are the non-dihydropyridine versus the dihydropyridine. Dihydropyridine, just remember, they end in the pene and they tend to act peripherally. So your two P's, pene and peripheral, and that's nice. Cytopine is ratapine, amlodipine, and cardipine, there's a bunch. Whereas your non-dihydropyridine have more of a myocardial action. That's your verapamil, your diltiazem. When they talk about one pill can kill, it's actually like verapamil in kids. There's a lot of different one pill can kill, but verapamil is one of them in children. So how are these patients going to present? Pretty easy. They're going to be hypotensive, bradycardic. They might have abnormalities in their glucose, but then they can have dysrhythmias, comas, seizures. The workup is going to be kind of like any other workup. You're going to get your EKG, your broad electrolytes, your lactate, your thyroid function, cardiac enzymes, because they might look, these are pretty easy to figure out. And how are you going to manage these? This is what I really want to talk about. So this is kind of the fun part. So in all your patients, first thing you want to do is ABC. So these patients can come in profound shock, like that patient with 60s, systolics of 50s, and heart rate of 40s. So the first thing you often do, these patients often get mechanically ventilated. They get invasive hemodynamic monitoring. You have to stabilize them first. Now, beta blockers can lead to seizures. Often you want to restore your circulation, and that will actually stop the seizure activity. If not, benzos are first line, barbiturates if benzos fail. For acute ingestions, this is where we're different from our acetaminophen and our salicylates. So several things. Activated charcoal is indicated just like our previous ones, 1 gram per kilogram. But now we can actually do oral gastric lavage. One thing you guys should think about, whenever you're putting anything into the stomach, you're going to probably vagal them. They're already bradycardic, so sometimes you have to give atropine before you attempt this. But depending on the dose of the severity, they're probably still going to want you to do an OG lavage. Try and get out as much of the medication that hasn't been absorbed as you can, because these people die from these overdoses. And then often they'll even do whole bowel irrigation. Patients going to love drinking all of that, go lightly. And then treatment. So there's a lot of treatments you're going to try. We'll go over each one of these. So atropine often doesn't work. You're having a beta block, but you might as well try it, and it's the same ACLS doses that you would use. Hypotension, they'll usually recommend starting with 10 cc's to 20 cc's per kg, seeing if anything happens. Most likely these people won't improve. So if they remain hypotensive, that's when you're going to need to consider pressors. So calcium. So in both beta blocker and calcium channel overdoses, you want to give calcium. The starting dose is 3 grams, usually given IV. You can repeat this every 10 to 20 minutes. They usually say even up to a total of 9 grams of calcium. So they'll give even more in calcium channel. This is kind of the indication for beta blockers. Calcium is still not working, and you're using calcium to treat not the heart rate, but the hypotension. So you'll see blood pressure go up. You might see the heart rate stay in the 40s. So the next thing you can try, technically this is the antidote for beta blockers, but most of the protocols actually were giving it for calcium channel blockers too. So how does it work? It basically has to do with your cyclic GMP. And so I'm not really going to go into that today, but it is a vasodilator, so you can actually get some worsening hypotension with this. But overall, it's supposed to increase the blood pressure and the contractility of the heart. The dosing is 3 to 5 grams given slowly over 1 to 2 minutes. If there's no response, you keep going until you get to 10 milligrams. If you have a response at how many milligrams you had a response at, you then start an infusion. So let's say 7 milligrams helps your patient's hemodynamics improve, then you'll start your infusion at 10 milligrams an hour. Let's say they didn't have any response, then most recommend starting an infusion at 10 milligrams per hour and just keeping it at 10, because there's probably some benefit your patient's getting even if you're not seeing it. The side effects of this are going to be vomiting. People have a lot of vomiting, so you want to administer some antiemetics before, but you just have to be careful with QT prolongation. Hypoglycemia and hypocalcemia can also occur. After that, this is the really cool one, high-dose insulin. We have a protocol here, actually, because there's some different ones throughout the country, but this is where we're going to use really, really high-dose insulin in order to help your hemodynamics. So we have a great protocol. I can go over it a little bit, but these are the goals you're going to aim for. You're going to aim for a MAP greater than 60, a CVP of 8 to 12, a cardiac index greater than or equal to 2.5, and you are going to basically dose it huge. So you normally in DKA we go 0.1 units per kilogram. This is going to be 1 unit per kilogram starting, and then you go up even higher. So this really is high-dose insulin. And people, you have to check glucose sometimes every 15 minutes. We have a whole protocol for it, but you're going to start them on glucose. And we even have like a matching glucose, because a lot of people are going to say, oh, they're hypoglycemic, we're going to stop it, but you should actually never stop this, because you're doing this to help with profound shock. So you'll see their MAPs go up, their blood pressures overall go up. And so your insulin dosing is going to be for hemodynamic monitoring. Your glucose you can just treat, and you will treat during the whole thing. And then pressors. So interestingly, epinephrine and norepinephrine were the ones I found that were recommended by our policy. When I was reading different articles, they recommended some different things. Sometimes they said you can try dobutamine, it probably won't work very well. They said you can try milrinone or phosphodiesterase inhibitors, but those can lead to worsening vasodilation and hypotension too. So I would probably stick to epi or norepi. And then intralipid is a possibility. So we talked about beta blockers, some of them being lipid soluble, like propranolol. You can give this, I really won't go over the dose, but the only time it hasn't been shown to be as effective as in high-dose insulin, but you want to hesitate. If you think this patient is collapsing to where they're going to need VA ECMO, you probably want to avoid this, because it can mess up the circuit, because you're basically pumping their blood full of lipids. And then ventricular pacing doesn't really work. You can try it, but it's not going to help you much. And then this one is pretty interesting. It's only in case reports. It's methylene blue. We've seen it used sometimes in severe vasodilatory like sepsis. And so they've actually been using it for some calcium channel blockers and beta blocker cases. And it basically acts by just kind of same mechanisms as everything else, inhibiting the synthesis of nitric oxide and affecting cyclic GMP too. So if you're at this point, there are a few cases where people actually completely turned around with it. If you have a patient who's collapsing and you're waiting for VA ECMO, you might as well try it. And then if you're a patient, you do all of these things, high-dose insulin, you try methylene blue, you do everything, they're still collapsing, or they even code, these patients often code, then they should be considered for VA ECMO. People have pretty good outcomes and tend to survive. So dialysis isn't really recommended. The one exception is atenolol, if you can convince nephrology, and that's just because it's water soluble. So the other ones, just you can't dialyze them. And then, okay guys, last question. What are the causes of medications that cause QTc prolongation? You guys want candy? Yes, you guys got it. Everybody gets candy. I'll pass it back around. All of these. All of these medications. These are tox questions. And then there were some things that this is a vast topic. Other things to know about are your oral hypoglycemic overdoses, your toxic alcohols, your different toxidromes, like your anticholinergic versus your sympathomimetic. Toxicology is a really cool subject. It's really broad, and hopefully you'll get some cool tox cases, some quick take-home points, and that's the end, guys. Any questions? Yeah.
So can you talk about serotonin syndrome? When you did mention neuropathy, so
yeah.
Still do that?
So you can. So it's not actually so there's not good evidence for it. So you can. We've used it here. Like I've had a couple cases where we give it. It's kind of like you can try it, but the only thing that's actually been shown to actually help is supportive care with benzos. So I know. Are you a benzo? Okay. Yes, lithium. I just see in the chat. Lithium is another one that can cause the hypobradia. Dialysis is important in that, and we have time to talk about it today.